Rightio, let's get going. So hello and thank you all for joining our webinar this evening on top tips for handling potential poison cases in practice. My name is Susie and I'm an RVN and I'm on the business development team here at VPG. Now I have a quick note to say, I hope our Irish listeners had a great Paddy's weekend and we're all doing well. Now, we are very excited to be here today with my colleague Katie Barker, who is the director at our Toxicology lab in Leeds, and Nicola Robinson, who is a vet at the VPIS. Now, we've recognised that toxicology is a vast and ever-changing topic, and what better way than to collaborate and join forces to bring you this webinar this evening. Now, both the VPIS and the VPG pride ourselves on being accessible while giving a high-quality service. So if you ever have any questions about a case, please do give us a call. Now, we will have contact details as well later on in the webinar. And not to mention, our pathologists and vets love a chat, so don't let them get bored. Now, we have a few housekeeping rules to go through this evening. So all attendees are currently set to mute, as you might have noticed. This is just to reduce any background noise. There's a chat box where you can enter questions as we go along, and we will have a Q&A at the end of the webinar. If any technical difficulties come up, please do bear with us and we'll aim to get things back up and running as soon as possible. Now, the webinar is being recorded and everyone who has registered will receive a copy of the recording after the event, as well as an attendance CPD cert. Now, it is my great pleasure to pass you over to Nicola from the VPIS.
Lovely, thank you, Susie. And good evening, everybody. It's a pleasure to be here this evening to talk to you about the approach you need to take when you are presented with a poisoning case in practice. I was in practice for 16 years and I know what it's like. They often come in when you're not expecting them or when you don't want them. It could be out of hours, or you might be sole charge in a branch practice, or might be when you're very, very busy. But knowing how to handle these cases from the very beginning really is crucial to achieving the right outcome for the animal. So let's just have a little look at what we're going to go through this evening. I'm going to just give you an update about the services that we offer at the VPIS, discuss the most common calls we get, just go through how to carry out a good risk assessment, discuss your treatment options, your initial treatment options for poisoning cases, and then the antidotes that are available and useful treatments that you might wish to stock. So looking at VPIS and APL, well, VPIS, well, I hope that most of you know about us already. We've been going for a very long time, so since 1992, and we're a membership-only service for vet practices. We are still the UK's only animal poison centre, and members can call us for full treatment advice and support for any animal that might have been exposed to something harmful. And you also get free recalls throughout the course of the case as well. Animal Poison Line is a different service, different number. It is a triage service only for owners, which we started 6 years ago. And we don't give treatment advice to owners for the obvious reasons that it's not really safe to or appropriate. We want to talk to vets in practice or vet nurses about that. They have to pay at the time a consultation fee at the time of the call, but that will be refunded if then the vet needs treatment advice and calls us on the VPIS line. So as far as our call volumes, we've been getting busier and busier, as you can see from the graph on the right. Our call volume has really increased an awful lot since 2018, so just after Animal Poison Line was launched. And now we have roughly 50-50 vet calls and owner calls, which is wonderful for us, because the more calls that we get, the more animals that are seeking our advice, and that's what we want. So going on to the calls that we get, well, it'll be very similar to probably the mix that you get in practice. The biggest group by far year on year is medications, well, drugs in general, in fact, because it also includes recreational drugs, and also, so not just human, but veterinary as well. That's about 40%. And then we have an equal number of plants, household products, chemicals, food, and pesticides. They're anywhere from sort of 8 to 15%, and smaller amounts of other agents. I mean, in fact, last year we had 39,000 different agents we were called about. So a lot of them actually are classed in other, which is 3%, but it can be literally anything. But you can see there on the 4.5%, you've got unknowns. And they're really important ones, actually, because they're the ones where you might have an animal that's come in that the owner doesn't know what it's been exposed to, but it's got signs that you are suspicious it's a poisoning and you want to give us a call, and we can potentially rule out toxins or give you some ideas about what it might be so you can question the owners more. Looking at dogs and cats separately, the top 4 does vary. So they both have non-steroidals in their top 4, but for dogs it's ibuprofen, and for cats it's meloxicam. And then the other 3 for dogs are the anticoagulant rodenticides. Always remember that with rat poison, although lots are still anticoagulants, you do also have others like vitamin D, and there's also alpha chlorelose, which is very nasty. And then chocolate and xylitol for dogs, and for cats, Lilium species, so true lilies, are obviously very toxic. Quaternary ammonium compounds, which is disinfectants, and cats, they are toxic to dogs as well, but because of cats' behaviour, because they roam and might go onto next door neighbour's patio where they've cleaned it for spring and used a disinfectant, cats tend to get on their paws and then groom a lot, so they are much more affected than dogs, many more cases for them. And then paracetamol, which they're much more susceptible to than dogs, so that's in their top 4 as well. And with the spread of species, well, dogs, no surprise, the majority of our calls are dogs. They tend to eat anything and then think afterwards. They are not well known for their portion control, especially Labradors. So we tend to find that the majority of our calls do involve dogs. And then about 13% cats, tend to be more fussy, although bizarrely we do get a lot of calls with cats eating tablets, which amazes me because when you want to give a cat a tablet, it doesn't seem to want to take it. And then we do have about 2 or 3% of other animals, including horses, rabbits, and a huge array of other species as well. So the risk assessment, how to carry out a proper risk assessment. This is a very, very important area in toxicology, and it's something we really pride ourselves on at the VPIS. The key is you really do need to assess the case properly to decide if you need to treat or not. That is your first thing that you need to do, and you do have time. It always seems to be a bit of a panic, and certainly owners can be really worried and very alarmed by the whole situation, and they're sure that you need to treat. But just step back a little bit. For the vast majority of toxins, you've got time to assess it properly. And the first thing you need to do is really question the owners thoroughly, because you need to understand exactly what the animal you've got in front of you has been exposed to. So a few examples is, if the owner tells you that the dog has had a number of iron tablets, it's actually only the elemental iron in those tablets which is a concern, and normally iron tablets are a compound. So that's what you need to work out first, how much is actually toxic of that tablet. It might be chocolate, that's a common one, but many products are not solid chocolate. And what type of chocolate is it? That's important too. If it's an antihistamine, which one is it? If it's a battery, how big is it? What type of battery? They do vary. Button batteries have different effects than the normal batteries, like AA batteries. What size was it? Was it chewed? Was it ingested whole? Vaping fluid, that's a common one to us. You need to decide, first of all, what's the maximum they might have had, the amount they might have had, but also how much nicotine is in it. That's the important question, because some of them have no nicotine at all and pose no risk. So those are the kind of questions that you need to ask the owners. And once you know what the toxin is that you're dealing with, you need to have a good understanding of what that toxin can do to that animal that you've got in front of you, what effect it's going to have. For example, if signs are going to start, are they going to be worse than the treatment that you're going to give to treat the poisoning? Because if the toxin only causes a very mild GI upset, for example, then that can be managed at home, and you don't need to obviously do any treatment. It needs to be assessed whether you need to treat at all, even if signs are going to start. And then so now you know what the toxin is and potentially what it's going to do. You then need to look at the individual case. Don't think, oh, well, because it's a toxin, I must treat this as I did the last case I had. Look at it individually. What have you got in front of you? You need to look at the weight of the animal, obviously normally the dog. how old is it, what any pre-existing conditions. It's not important for all toxins, but it is very important for some. And then try not to have blanket protocols. It's something we come across quite a lot, actually, that vets say, no, well, we always treat our rat poison cases, or we always treat xylitol. But what you need to do is know what the toxic dose is of those poisons, because without knowing that, you cannot accurately decide whether to treat or not, and you can't have an accurate risk assessment. And if you don't know the toxic dose, and of course, totally understandable if you don't, then we will have those, and we can certainly help you. And try not to use information from previous similar case. It is so tempting to say, oh, I had one of these last week and I'll do the same thing. But actually, our information changes. So just be a little bit careful there. We did have a case, it was several years ago, about 8 years ago now, where the same vet practice called us about a similar sized dog that had both eaten a very similar amount of chewing gum. And for the first one, we told them not to treat. And when the other call came in a month later, we told them to treat for xylitol. And the practice called us afterwards. They called me, in fact, and said, clearly you've got one of them wrong, because one you've either undertreated or one you've overtreated. We don't know which. And I had to explain that between those two calls, Wrigley's had started to put xylitol in their chewing gum, and that's why our information had changed. So if the practice had not called us for that second case and just used the previous case, then that dog would have been undertreated and may have been in trouble. And then understand the importance of timing. So you need to think about when it happened, and therefore, oh, sorry, I've missed one, haven't I? I'll come back to the timing one, sorry. Just relay specific evidence-based information to the owner. So when you're talking to the owner, try not to be too vague, really understand what you're saying and make sure that it is evidence-based. So for example, first of all, will signs actually start? There's no point going through all the signs of a toxin when actually haven't had enough to call signs. Just reassure the owner they go home and not worry. If signs are going to start, when are they going to start? How long will they go on for? Can they be managed at home? How much that toxin needed to cause a problem, you know, for example, how many tablets or how much chocolate. And also be aware that owners can tell you something's been eaten, and if the signs aren't consistent, then say that to them. Don't assume the two are linked, because you may well find something else is going on. And then yes, back to timing. If you know when signs are expected to start, and if the pet's not showing these signs, it might be that you're out of the woods and you don't need to worry. So for example, some toxins, plants, for example, it might be between 2 and 4 hours you're meant to get signs. If the owner only realizes 10 hours later and the cat or dog is okay, then you don't need to worry. You need to know if you're out of the woods or not at that point. And just some examples of where there's been some wrong risk assessments on clinical notes that I've been sent, or cases that I've had discussed with me. These are all animals that have actually been treated in practice. There was a dog that was treated after having 7 levothyroxine tablets, and it could have had 150 tablets before treatment was needed. There was a dog that had a conker a couple of days before and had some diarrhea, but it was eating and drinking fine. No treatment was needed, but it was treated for conker poisoning. There was a clinical notes which had this on it. It had, this common plant is extremely poisonous to all species, and all parts are very poisonous. And actually what had happened was a dog had eaten the one part that wasn't poisonous, but the vet hadn't realized that. This is a meloxicam. Another one was a meloxicam overdose, where the vet had told the owner it must be seen as an emergency treatment, and the treatment will last a few days. But actually, if they'd rung us, we could have told them the meloxicam overdose was under our treatment dose, and that dog or cat, I can't remember what it was now, wouldn't have had signs at all. Another one, even a small cigarette butt can mean serious illness or even be fatal. Well, actually that pet was asymptomatic, and the vet told them all the signs of nicotine poisoning and then started treatment when it wasn't needed. So just thinking of those cases, just a call to us, either the vet calling or the owner calling APL, that would have saved obviously all those animals the stress of treatment. And it's ideal really to try and get those calls at the very start so that we can help you if you need it. So let's look at a few case studies and of ones that we have had with us. Let me just get that for you. Right, so our first case study, a very typical case you might get in practice, which is a Labrador, 5 years old, so middle-aged, 30 kilos, eaten 29 Bassett's vitamin omega-3 multivitamins containing an awful lot of vitamins for 12 to 18-year-olds half an hour ago. And the owner called the practice, but there was no vet there at that time. There was only a nurse and receptionist. And there are a few scenarios here or information you can give the owner. The first is you might look at that and say, well, actually, I don't think that's going to be a problem. You can observe it at home. And if your pet is showing signs, then bring it in to us at that point, and hopefully, obviously, the vet will be back at that stage. You could think, well, actually, it's quite a large number, 29, so it could be a problem. So let's try and get you in, but let's try and just call either us, you can call us directly, or ask the owners to call on their way before they get there, so that we can assess what you need to do next. Or one other scenario possibly is that you could recommend emesis at home using a handful of salt, restrict water, and then repeat the salt if there's no vomiting. Well, it won't surprise you that scenario 3 is not the ideal scenario, and is one that we would never ever recommend. Scenario 2 is ideal, and scenario 1 absolutely fine if you've done your risk assessment properly, and that's the key here. So don't just guess that it's unlikely to be a problem, do a risk assessment, and if your risk assessment is accurate, then you may well be able to leave that dog at home. Unfortunately, it was scenario 3 that happened with this particular dog. It was told, the owners were told, to give a handful of salt, and this is Jambo, the dog in question. They were very, very worried, the owners, so they gave the salt, and the dog, Jambo, wasn't sick. So they gave another handful as they'd been told, but then they got really quite worried because he still wasn't vomiting, and they didn't want to give any more salt. So they decided to call a different practice just to hopefully find a vet to talk to. And the second practice advised them to call animal poison line, and they spoke to me and told me about the multivitamins. So I looked at all the ingredients. I can't remember how many there were now, 13 or 15, something like that, and picked out the ones that are a problem, looked at the toxic doses, and advised them that actually, because of his weight and the amount he'd eaten, actually there was no treatment required. And it was then that they told us about the salt. And unfortunately, the salt was over the treatment dose. So Jambo did have to go into the vets at that point, and he had 2 days of treatment. And clearly, there are a couple of issues with this. Going back to our risk assessment, this could all have been avoided. All this treatment for Jambo and this upset to the owners could have been avoided if a proper risk assessment had been carried out. You had to look at his weight, assess that toxin, which of those vitamins were going to be a problem, then think of the toxic dose, and get the evidence about the course of action that you're going to carry out. And is there evidence to say that that's the right treatment to do? And if you don't know, then obviously come to us. This is why VPIS exists, and why we love our job, and why we're there to support you in practice. We're here 24 hours a day for this very reason, to really help you. But the other big reason why there's a problem here is that the relationship between a client and vet is also changed. You have a sick dog and a large vet bill. It was £900, and the owner knows why they've got that vet bill, and it ruins the trust that they've got with their vet, which obviously no one wants. What we all want is to give the right advice at the very beginning, so the pet is treated appropriately, and everyone is happy that the right approach is followed. And the second case study is a lovely little pup, Dobby, who is a 4.5 kilo poodle cross, 16 weeks old, and the owner called us on the APL line saying that he'd had up to 6 ramipril tablets, 2.5 mg, an hour before, and they called us and we advised no treatment was needed, and that it was good news. It was only then that the owner said actually they were at the vets and they've already carried out an emetic. We explained that no further treatment was needed, but because we'd told them initially that actually this dog had needed, it actually turned out to be hundreds of tablets before we'd have recommended treatment. They were upset and they went back into their vets and refused to pay the bill, which is clearly what none of us want. The vet did call us afterwards and said, and I'll show you the book, you may well know this book, this is the Canine and Feline Poisons guide that we did with the BSAVA, they'd looked in this book with the ACE inhibitors, and that was a treatment in the book. But what they hadn't realized was that the book has, they're actually, I think it's 13, 12, so ACE inhibitors, which vary in their toxic doses from 3 milligrams per kilogram up to 500 milligrams per kilogram. We can't put those in a textbook because we are behind the scenes reviewing our information all the time. We review the literature, recent literature, and that includes human toxicology as well as veterinary, and we also review our cases. And therefore, if we put our toxic doses for all of those in a textbook, they'll be out of date, potentially within a few months. That book is meant to be, that is the right treatment for an ACE inhibitor, but only when you know which ACE inhibitor it's had and if treatment is required, which in Dobby's case, it wasn't. And then just looking at the initial treatment options open to you, well, these are the top few, which you'll all know, and they're the ones that we hear about an awful lot, and many of them are, well, not many of them, but some of them are given when they're not needed. And so I just want to just highlight areas which might be interesting to you and help out decide whether it's needed or not. So when you're looking at whether you need to give an emetic or not, that probably is the biggest one here, because from us, there's a huge over-reliance on EMES as a treatment, irrespective of whether it's indicated or not. It just seems to be the go-to. And I think there are a few questions you must think about beforehand. So the first thing is decide if it's necessary. So as we talked about already, it might be below a toxic dose, it might be an agent of very low toxicity, so you don't need to do anything. Also, has it already vomited? You don't need to give another emetic if it's already been sick itself. You need to move on to other treatments if treatment's required. Is it going to be effective? Well, that needs to be on time frame, and that varies from toxin to toxin. There are some, they're just not going to get there quick enough for you to do it. Unfortunately, there are some toxins which are very rapidly absorbed. There are some where they may have had a very small amount of liquid or a small amount of a cream of some sort. And again, you're not going to get much up with emesis, and therefore it's worth going on to other treatments. Or they might have eaten a medication which is an antiemetic. So they're then not going to be sick. So again, that's something to think about. And then, is it possible and safe? You know, is it contraindicated because of the condition of the animal, or because it might bring on seizures? It might be corrosive, so you don't want it coming back up the esophagus, or too heavy, so it might get caught in the esophagus, for example, batteries. So those are all things to think about. I mean, I certainly, when I was looking through clinical notes, picked out a couple of things over the last few years, and one of them said it's not possible to estimate the risk of poisoning, so I choose to do emesis. And that was a rat poison case. Well, it is possible, in fact, to estimate the risk. That's something that we have here and we can do for you. Another one said the risk of raisin toxicity is eliminated if emesis is successful. But you need to think, how do you know if emesis is successful? Because it only 40 to 60% of stomach contents comes up. So unless the owner is absolutely sure how much has been eaten in the first place and you can see it, then that might be a possibility. But you don't always know, and it may be that they come up, this toxin comes up and some of it's been absorbed, the toxin itself has been absorbed, but maybe the outside, the capsules or whatever it is that's been eaten comes up in the vomit, and you think that it's all safe and it's not. And sometimes it's easier to, or not easier, but better to go straight on to gastric lavage, and that might be the better option. Again, we can advise you on that. The other ones, obviously very useful treatment, activated charcoal, which binds to toxins, but not all toxins. So again, think, will the toxin bind? Do I need to give one dose or repeated doses? And what other treatments am I giving? Because you don't want to give activated charcoal plus oral medications, otherwise they'll be absorbed and not work. And the last two, intravenous fluid therapy and blood tests, think if they're needed, think how the toxins are excreted or what changes you're going to see on those bloods if you take a test and when you take them. There is no point taking them after 3 hours if you're not going to see anything, unless you definitely want a baseline. But think about it, and it may not be needed at all. So again, worth checking before you start. And just sort of finish the last couple of slides just about antidotes and what is useful to stock. Sadly, there are not many antidotes in veterinary medicine or toxicology. The four most important: acetylcysteine, Sorry, let's just go back. Acetylcysteine, that is for paracetamol. Vitamin K, which is for the anticoagulant rodenticides. Naloxone for opioid toxicity, and ADA antivenom. And the ones that are useful to stock, and by far the most important, if there's one thing that I would like to do as head of service at the VPIS while I'm doing this role, is try and get as many practices to stock lipid infusion as possible. It doesn't work on every toxin, and it's mainly on neurotoxins, but it is a fantastic, cheap, easy treatment that can reduce recovery time significantly, because what it does is it actually draws out the toxin from the blood rather than treating the signs of the toxin. It draws out of the blood, so it takes it away from the body. It is a fantastic treatment, and as I say, very, very good value. I think it's about £25 and a shelf life of 2 years. And the other ones, methocarbamol, skeletal muscle relaxant, which is very good for the neurotoxins which have mild signs, twitching, tremors, that kind of thing. Misoprostol, which is a synthetic prostaglandin, which we use for non-steroidal toxicity, and cyproheptadine, or Periactin is a trade name, which is for serotonin syndrome. That's useful to know where to source. But if you can't source it or you don't have it, don't worry. There are some of the corporates which have these schemes where they, in their practices, stock these treatments, and we can direct you to the right place if you do need it. So you can always call us and we can let you know where to go. And finally, just a flowchart for vet practices. This is something put together recently when we had many calls from people saying we really would like to know what are the cases where we can't ask owners to call you and which are the ones we should ask owners to call you. So we put this together for receptionists and for nurses in the prep room, and you can put it up. They're all laminated and just goes through what you need to do and the different numbers, different services, so that you use them and we can support you to the best that we can for all these cases. And those are our contact details. As Susie said, we always love to hear from you. And if you want anything from us, like the flowcharts or any information, then of course you can email us, you can ring us. We are here 24 hours a day. So we always look forward to hearing from you. And that's all from me. I'm now going to pass over to Katie Barker, who will talk to you about toxicology testing.
Thank you, Nicola. I hope you found that interesting. It was really good. Yeah, thank you very much for joining us this evening. It's great to see so many people online as well, so fantastic. Yeah, toxicology testing. So I mean, the picture's, you know, 1,000 words, needle in a haystack there. It can be quite tricky, and unfortunately, you know, some people seem to think we're CSI and we're not. So it's really, really helpful, as Nicola's mentioned, that getting as much information, risk assessments as possible is really helpful for us. Otherwise, we're presented with samples and we have absolutely no idea where we're starting. And I appreciate that does happen sometimes, and we have sort of plans in place for that. But as much information, what's been ingested, any material left is really helpful from our point of view. So I'm just having a few problems with my mouse there. I'm not sure, Catherine, if you can assist there. Thank you. So why are we going to test? So we're going to test for many reasons. We're going to do it to exclude the presence of a toxin, which is always good. Identification of toxins potentially involved in cases, optimize the therapeutic management of those cases, determine the prognosis, assist in cases of sudden death, suspected toxic material identification, which we have sometimes, and also assist in prosecution cases. And unfortunately, we have done a few here in VPG as well, when we've had toxic material sent to us. So we have a list of panels. Catherine, it's not working for me, I'm afraid, if you wouldn't mind. Sorry. Thank you. So we've got quite a few panels, and again, we're the same as VPIS. We're always happy to help you on the phones if you want to give us a call, and we can talk you through some of the different panels we do. And again, they're very much dependent on the symptoms that you're seeing, and also if you've got evidence of ingestion as well. If you could move on, thank you. And again, that's just following on from there. As I say, it's helpful if you do just give us a call. We can direct you in the right way. So how do we do this? Well, there are different methods for toxicology. That's one of my colleagues there, Chris, on the GCMS. So we do a lot of the work on the GCMS. We've also got, we run on liquid chromatography as well, which is what we will use to do some of the analysis for some of the toxins that we can't pick up on gas chromatography. So it's a very, very long, involved process, as I hope that you will realise when we get onto the insides of the analyzer. We've got an overview here of the gas chromatography, and I've picked the gas chromatography because, as I say, that's the one that we will use most often and not for the small animal cases. So we actually use hydrogen for our carrier gas. Now, a lot of people can use helium, but unfortunately there seems to have been a global shortage of helium for quite some time. So hydrogen works just as well. If anything, it actually moves through the systems a lot quicker. So it has a faster velocity on the mobile phase. So basically, just a quick overview, what will happen is the samples will come in. As you'll see when we move on to sample types, we have the ability to homogenize samples, so we can mix, sounds quite disgusting really, but we can mix blood and urine, tissue samples all together, which will give us a better chance of actually finding any toxins that are present. So basically, once we do that, we run on liquid extraction. So the depending on what kind of toxins we're looking for is dependent on what we use as solvents. So this is where the sort of chemistry side comes into it. And basically, they are extracted and they are reconstituted with the correct solvent and injected into the pot at the top there. Basically, the column itself, the one that we've got at the moment, is a fused silica column. This is what they call the stationary phase. So as the oven, which is where the column is situated, starts to heat up, basically the gas will move through and push all the compounds through the stationary phase. And again, depending on the interaction of those chemicals, will depend on how far and how quickly they move through the column. And that's what you will see called as the retention time. When the compounds have reached the ion source, they're then focused into the mass spec, which will then identify the different peaks and things. If you could move on for me, Catherine. So we'll have something like this. So if you imagine when we start, the oven starts at 60 degrees, nice cool temperature, and it's a bit like a race. So everybody's lined up at the beginning. And then as the temperature starts to increase, some of the more volatile compounds will actually elute very quickly through the system, and the other sort of more heavier compounds will sort of, slowly get there eventually. So as we move through, we can ramp the temperature up to in excess of 300 degrees to just get those last few compounds through there. And then what we have on there, that's actually a paracetamol chromatogram. Each peak will represent a compound, and not necessarily all of those compounds are toxic. If you can see the very last peak, about 16 minutes, that's actually related to cholesterol. Very big compound comes through right at the very last moment. Thank you, Catherine. So when we delve into each of the peaks, we'll see something like this, which is your mass spec. So basically, what that is each line represents an ion, and each ion is relative to a compound. So then what we can do is we can do what we call a full system scan, or we can just scan for one particular ion if we know we're only looking for one compound. And basically, what will happen, if you could move on, Catherine, thank you, is we'll have something like this. So basically, this is a chromatogram, and we've delved into one of the peaks, and we've selected some of the ions that are present. This is one for methiocarb. And basically it will screen it against the system. There are in excess of 30,000 compounds on the database, and it basically will screen it against everything that's on there, and it will pick up a match. And as you can see there, we've got a 94% match to methiocarb. which is fantastic. Anything over 90% we're pretty sure is there. Sometimes we can rerun them and just double check, and we're always updating the database as well, so that's really helpful in terms of that as well. Thank you, Catherine. Okay, so what do we need? So suspect material. If there's any material left, if our lovely Labrador has been eating something in the park and there's something left, then pick it up. Everybody, I'm sure, will have a bag with them, so it's really important to keep that kind of material. Vomit or gastric lavage. We do have cases where we've had nurses ring up and say, oh, we've thrown the vomit away. Don't do that. Just keep it. It's one of the real key things that we can use to work out toxin exposure. So absolutely fantastic. If the owners have called and the dog's vomited at home or the cat, then please ask them if they can find a container to seal that and bring it in as well. Blood, again, really helpful. Heparin, EDTA, clotted. Ideally at least 2 ml if we can as a minimum. It's very difficult, and as you can imagine, the more volume we have, the more likely it is that we will detect something. And again, as I mentioned, we can pool all this together as well. Urine, again, great for catching the toxins that are cleared, but we do need at least 5 ml. Absolutely no feces. We have this question quite a lot. But basically there's too much organic matter within feces and it doesn't give a clear chromatogram on the system, so we wouldn't advise on that at all. In cases where you've got post-mortem cases, liver, kidneys, stomach contents, heart, blood and urine are great. We can take that. If you're not able to do a full post-mortem at the time, it's still possible to get the gastric contents, and if you can do cardiocentesis for the blood and urine as well by cysto, then that's great as well. And all of this material can be frozen and stored, so it's a good thing to write into your triage and your risk assessments to make sure you get as many samples at the time, because once the vomit's gone or what have you, then we can't get that back after that point. Thank you, Catherine. So we'll just finish with a couple of toxicology case reports. So these are all reports we've actually had here. So with the first one, we've got 1-year-old dog found at home unable to stand, salivating, taken straight to the vets, had a seizure on arrival, found to be hypoglycemic and hyperkalemic on the bloods. It was administered diazepam, glucose and potassium. No improvement at all, so it had a shot of dexamethasone and some glucagon. Basically appeared normal glycemic transiently only. Started seizuring again, so it was given phenobarbital and then went into cardiac arrest. So the blood analysis on the insulin was greater than 300, and bear in mind the top of the range there is 30. So we've got differentials there that could be relative. We've got insulomas, endogenous insulin administration and xylitol toxicity. So as you'll be aware, there's not many reports of insulomas in dogs that are less than 3 years old, and this dog was a year, so that was unlikely, and there was no endogenous administration either. So blood tests were submitted to us and we found xylitol. As you know, xylitol is quite a common thing now. It's found in many mints, and it's used a lot as an artificial sweetener and chewing gum and that kind of thing. So it is quite a popular one that we do see coming through. It's rapidly absorbed in dogs, which obviously produces the hypoglycemia, and then we get a few other bits and pieces that could go with that, high insulin and obviously the potassium movement then within the cells given the hyperkalemia, and again the phosphate can be affected. Worst case scenario, hepatic necrosis may also be seen as well. Thank you, Catherine. So it's a strange one, is xylitol. Humans, rats and other mammals actually absorb it relatively slowly, which is obviously why we don't have these effects when we're chewing gum or using mouthwash, toothpaste, that kind of thing. It has been seen sometimes with delayed absorption in dogs. Prognosis is usually pretty good, although when we start to see the hepatic changes in the hyperphosphatemia, we would be looking at guarded to poor prognosis, unfortunately. So very, very important to keep that chewing gum out of the way, particularly of the Labradors, as Nicola has stated before. Thank you, Catherine. And sure enough, here we go. So we've got Holly, our 2-year-old female neutered Labrador. So Holly presented acute onset of ataxia and nystagmus, depression 40 minutes after eating some bones in the woods. So we had progressive recumbency, torpor, and reduced gag reflex. The samples were taken, and it transpired that these were present high levels of pentabarb. Basically, what had happened with Holly is she had eaten a carcass that had been euthanized and buried in the woods. So this is where you get the possibility of secondary poisoning. So it's really important to keep an eye out for that one, as pentabarb doesn't always degrade within the carcass, and if the carcass is still there and it's worth chewing as they will dig it up, then absolutely, if you're presented with that, that's a highly likely possibility. Thank you, Catherine. And there is the chromatogram that's associated with Holly there. So we've got pentabarb at rank number 1 on a 91% possibility, and that was a combined blood and urine sample that we did together. Thank you. Oh, if you just drop back, thank you. So another case here, 2-year-old female border collie, increased panting the night before, getting progressively worse. Emesis was carried out in the car. Not sure how they did that, but that's what we had on the history, and died unfortunately within an hour of administration. Background history on this dog was it was a farm dog, so we had stomach contents which were obtained at post-mortem. We performed the toxicology on the stomach contents here to reveal high levels of nitroxinil. So nitroxinil is a flucicide which is commonly used in cattle and sheep, and dogs are unfortunately very sensitive to the toxic effects of that. And again, similar to our previous case of Holly, this dog had access to a carcass on the farm that unfortunately had been treated with nitroxinil. So it was quite an unfortunate case, that one. And these are our favourites, the party dogs, we call them. Yes, these ones, we often get the cases. So we have a 6-month-old Cocker Spaniel puppy. So the puppy was found in an agitated state during a house party. That was a house party with people, not the animals. And it was found very excited with periods of depression. The dog started vomiting. So we had a sample submitted for a blood sample for toxicology, and basically THC was detected. So that's the metabolite of cannabis. So detoxification with activated charcoal. At this stage, the puppy was kept quiet and warm. Diazepam was given just to control that agitation. No further signs developed, and the dog recovered absolutely fine. Cannabis is a very strange one with dogs, and if you have a case where you're suspecting a drugs of abuse, and sometimes we will see these cases where there could be a few different drugs involved, unfortunately. Cocaine's another one we see quite a lot. If you are submitting, if you can get a urine sample, we can do drugs of abuse, a full drugs of abuse panel on urine, but it's really important to send a blood sample as well if you're looking for cannabis in particular. The way that cannabis is metabolized is very different in dogs than it is for humans, so you're very likely to see false negative tests on human kits, and there's a lot of human sort of dipstick type tests out there for cannabis. Absolutely avoid them completely, as I say, because of this effect. It's very, very rare that THC is ever excreted in the urine in a dog, so bear that one in mind, that if you think cannabis is there, get a blood sample as well as your urine. Thank you for that, Catherine. So just a bit of a recap really on that. Make sure you take multiple samples and take them early. Always take blood, urine, stomach contents, any material, label, date, and store them. They can be stored in the fridge or they can be stored in the freezer. It will not affect the testing at all. Consider and discuss other likely differentials. As you may know, some of these cases may present as a toxicology case, but there are other differentials that could be considered as well. So it's not always the first assumption that the dog has ingested something that's poisonous, or cat. Certainly get advice from the VPIS. These guys are fantastic. This is what they do. They've put so much time and effort into doing all the research for you. So please do use them. Absolutely. And also you can give us a call anytime and we can speak to you about cases as well. Also consider likelihood of detection as well. Again, as I've mentioned, this is reduced massively with sample volume. So again, multiple samples early and the volume is really what we need. Unfortunately, we do have, as I say, cases of legal nature. So if this is a possibility, please give us a call and we can discuss how to support you through that in terms of chains of evidence. We often see these sometimes in post-mortem cases as well, and we have to follow those through correctly just in case they go to prosecution. So if you do think it's a legal case, collect your samples, date, store, make a note of who's taken them, and then give us a call and we can talk you through the rest. And then obviously submitting for the appropriate panel. So again, with the VPIS may give you some advice on that as well, or you can give us a call and we can talk you through those panels as well. Thank you, Catherine. And there are our contact details, and again, everything will be available there. There's information on the website as well, but certainly we love talking, as Nicola mentioned, so pick the phone up, drop us an email, however you want to contact us, and hopefully we can really start to nail down on this and protect those pets that we love the most. So thank you very much.
Thank you, Katie. I'll just see if we have any questions. So Nicola, I think this one's for you. The question is, I'm a locum and would like a flowchart, please. How do I get one? And what is the cost of the owner poisons line?
Okay, so for the flowcharts, if you're a locum, all you need to do is drop us a quick email. It's the actual, you should get a recording after this and the details are on there, but it's basically admin@vpisglobal.com. So quite easy, and you can just ask for a flowchart and tell us where to send it and we'll do that for you. And the annual poison line is £35 in hours, and our in hours are Monday to Friday, 8 in the morning till 8 in the evening. And it's £10 extra all night and all weekend and bank holidays, so 45.
Thank you. Perfect. And then Katie, this is a question for VPG. What is the turnaround time for a case?
That very much depends on what particular case you are looking for. Again, as I say, there's a huge variety of different panels there that we can do. Things like ethylene glycol, the general toxicology panels, those kind of things we can turn around in a day as an urgent for an additional fee. Generally, turnaround time is about 3 to 4 days, depending on when we receive the sample. Some of the other tests that we do tend to take a little bit longer. There's sometimes quite a lot involved in those, and anything that involves organic compounds, that kind of thing, can actually take a couple of weeks. But the general bulk of the small animal toxicology work, as I say, can be turned around within the day if it's urgent, or 3 to 4 days.
Perfect, thank you. We've had a question just for VPG contact details, so we have them up on the screen again, and we will follow up with an email with contact details on there. And Emily has asked, will this be available on catch up as you missed the beginning? Yep, that's absolutely fine. So we will send a recording through when we finish up this evening. Right, do you have any other questions from anyone? Right, I have one here. Katie, this is for BPG. If ingestion is confirmed and assuming absorption occurred, but nothing is detected, what class of compound could it be? Does the technique always detect something, even if there is no match in the database? Sorry.
So unfortunately we can't detect everything. It's not a possibility to do that. So we will always do the best that we can with the samples that we have. Again, clinical history, symptoms on presentation and things like that are really helpful for us to try and pinpoint. But as going back to my original slide, it can be a bit like a needle in a haystack sometimes when you're looking for these unknowns. I'm not sure, Nicola, if you have anything to add from the clinical side of that.
No, I don't think really. It's very difficult, isn't it? So no, I think you've covered it. You've probably covered it, Katie. I think it's very hard if you've got a complete unknown. I think probably from the point of view, certainly from the lab, it helps have some pointers, doesn't it, about what you're testing for. From our point of view, we can help quite a lot with unknowns. We have a lot of unknown cases, as you saw on my presentation, and certainly the clinical signs might give an indication if they're showing signs about what you should be looking for. But no, very difficult, I think, if nothing comes up on the screening.
Great, thank you. Just seeing if there's any more questions. So we have a question here. What are the main questions that are asked by customers?
I presume that's to Nicola, is it?
Yeah, I think so.
Oh, do we mean on the animal poison line? Is that what, from owners, do you mean? Or I'm assuming that's what the question is. What the most common ones? It's similar to what I put on the presentation, which is the most common ones will be similar. The cases that I showed was the overall, so the most common ones would get, without a doubt, are, well, they call about anything, but the most common ones are medications. Obviously, all of them are calling because they want to know what to do, and particularly out of hours, whether they need to go to the vets or not. But I think the majority, as I say, well, not majority, 40% are roughly drugs, but we do get everything. So those, I'm not sure if that I've answered the question exactly correctly, but that's what they are calling about. The majority, as I say, are, in fact, most are referred by vets to us first of all. About between probably 80 and 90% call the vets first, understandably, and the vets say, well, call animal poison line first if it's not showing signs, and the owner will then call to find out if they need to go to the vet surgery or not.
Perfect, thank you. We have another question here. Adder antivenom was mentioned earlier. How frequent are adverse reactions to antivenom itself? How does that relate to when you may choose to or not choose to use it?
It's very, very unusual to get an adder antivenom reaction, and it's not an indication, it's not a reason, sorry, not to use it. There have been these reports, I know, about anaphylaxis and saying if a dog's had it previously, but I'm afraid to say that if they do need it, not all cases need it, that's the first thing. But if they do need it, that would not be a reason to not give it. I'm afraid I haven't got the percentage. I could probably find it actually if that person wants to give their name perhaps, or afterwards wants to contact us at the VPIS, just email me, email us or call us, then of course we can look into that further for you, the actual percentage, but it's very, very rare.
Thank you. We have another one here. Do you still recommend emesis, bloods and fluids for grape toxicity? We have always done this as good standard, but recently tried to send a dog 2 out of hours for this. He said it was no longer recommended. I
knew that grapes would come up. I couldn't believe we'd almost finished and no one had mentioned grapes. I mean, that's unheard of. So whoever asked that, yeah, absolutely. Great question. We changed our advice a few years ago. they still pose a risk to some dogs, but not all dogs, and that is the real problem. They are an extremely frustrating toxin. Probably around 10% of dogs are susceptible to raisin toxicity or grape toxicity, and the rest probably absolutely going to be fine. They're not even susceptible to it. So they will have no signs, regardless of how many they eat. There has been recent evidence which shows that we are just getting to a stage where we might get a toxic dose. We've always felt previously that didn't matter how many they ate, it could be a small amount in a large dog that can cause a problem, or a small dog can eat a whole punnet and not have a problem. But we are not necessarily treating them all now. But gold standard has to be that if we don't know if that dog's susceptible and they've had some grapes or raisins, that you do the gold standard would be to do a gut decontamination, and that includes repeat dose activated charcoal, followed by fluids, and obviously checking the renal parameters 24 and 48 hours. It's got to be an informed discussion with the owner to discuss the risks. If you do say to them that majority are not going to have a problem, then they may decide not to keep the dog in, but at least do the gut decontamination and the renal testing. I think that probably is a minimum. What I would say is there is no evidence in the literature or our cases, and we have thousands, as you can imagine, that one grape or raisin or sultana will cause a problem. So if you have a case where a child or anybody's dropped one on the floor and they know it's one, then you do not need to treat. They can stay at home.
Amazing, thank you. And then we have another question here. Is there any new information change about onion toxicity?
Nothing new, but onions, again, a little bit tricky in that the actual toxin, the amount in onions, is because it's a vegetable and it grows, it can be variable between onions, and it's also the same for garlic and chives and leeks, spring onions, all the same family, the allium family. There's no new information recently, but we have so many cases on this that we can give a very good indication about where the signs will start. You're probably aware it's Heinz body anemia, and that doesn't start instantly, so you have got time to really do a good risk assessment, decide whether treatment's needed, and it is dependent on the weight of the animal and what they've eaten, obviously, which type, and we do it on a amount of a weight per kilogram body weight, because we've got that from our cases. That is a toxic dose that we have put together to make sure that we do a proper risk assessment on them. Not all cases need treating, and there are lots. If it's just a piece of garlic bread with a small amount of garlic butter, in most dogs that's going to be fine, but there's no new information at the moment that is similar to what has been for a few years, in fact.
Brilliant, thank you. There's a follow-on question here for the grape one. Is grape toxicity down to a mold on the grapes, but as you say, it doesn't affect all dogs?
Did you say mold on the grapes?
Yeah.
No, no, it won't. It's not a mold. There is recent evidence that it's due to the tartaric acid in the grapes. A lot more has come to light in the last 2 years. So we are actually at the process at the moment of looking at all the information and assessing it. And I think we're going to probably we may change our information fairly soon. But no, mold is a big problem in dogs. It is the mycotoxins cause neurological signs if they are moldy. That is all moldy food from a compost heap or just a bin, a food bin, for example. That's a classic toxicity. But no, we do not think that's the cause of it. We haven't got to the bottom of it yet, but we are pretty certain it's due to the tartaric acid content in grapes. And that's also, just for vets and vet nurses to know, that all tartaric acid can also be in other foods. For example, some sweets have it in as well. The sweet and sour, the ones that are sour, like sour snakes and things, that's due to tartaric acid. Normally not a large amount, but we are getting a lot of information at the moment on tartaric acid and the amounts in those different products, so we'll have all that information.
Brilliant, thank you. I'll just see if there's any more. I think that might be all the questions. Yeah, it looks like that's all the questions. So thank you everyone so much for joining this evening. If you do have any follow-on questions, just give us a bell and let us know, and we'll send you the recording and a CPD certificate as well.
Thank you.